So first of all, history taking is very important for any patient. Without proper history, we will not know which system to approach. This is basically the first way to approach a patient. And then by proper history taking only, we will know that how to plan our diagnosis, then our treatment. So this is the first step while seeing a patient. So how should we approach a patient? Firstly, you should look confident. Only if you look confident, the patient will open up to you and he will say what problems he is having or facing. Then we should welcome the patient by saying hello. Then we should shake the hand. Then introduce yourself. If you are a doctor, tell the patient that I am doctor this or doctor that. Or if you are a medical student, you tell that my name is this, I am belonging from this college, I am come here to examine you or to take your history. You introduce yourself properly so that the patient will feel confident to express everything in front of you. Then to reduce the nervousness of the patient, you should initially tell the patient that what you are going to do with the patient. You tell him that I am going to ask some questions, he will answer it, and then by these answers I can come to a diagnosis or I can come to a conclusion. So in a hospital, there may be several patients, there may be several beds, 10, 30, 20 beds. So if you are exposing a patient in front of everybody, obviously he will feel shy. He will not express everything, he will not tell everything, he will not show his body parts which is affected or not. So you should put a curtain and there should be a maintenance of privacy so the patient feels safe and he can open up in front of you. So you make sure that thing. Then firstly in history, we will ask about the particulars of the patient. So in particulars, firstly we will ask the patient's name. So why the name is important? Suppose if the patient is here and I am calling him like, oh you come here, and there is another way I am calling him by his name, that Mr. This, you come here. So obviously that patient will feel closer to me. He will know that okay, the doctor knows me, he is paying attention to me. So the patient will express more. And if you are telling someone, okay you come here, sit here, he will think that the doctor isn't even seeing me properly, he doesn't even know me. So you should call everyone by his name, Mr. This, Mr. That or Mrs. This. Then you should know the age. Age is obviously important because in some age groups some diseases are more common. In children some diseases will be more, in adults some diseases will be more, and some diseases are there which will be more common in the geriatric age. Geriatric means in the adult age, in the like above 60 or 70. So those people are more likely to have those diseases. So the age is important. Again, gender is important. So some diseases are specific to the male or the female gender. So then you will ask the address. By the address you will know that like in our state, in Tripura, malaria is more common in compared to other states like Delhi or some other more developed states. So here malaria is more common. So by knowing where the person is residing, where is his home, you can know that you can initially think of a diagnosis that okay, the patient is having fever, so might be he is having malaria. So in some remote areas like in Rajasthan, suppose someone is having fever, you will not firstly think about malaria in that case. You may think of something else which is more common there. So this is the importance of the address. Then you will ask the occupation of the patient. Like in some coal miners, some diseases may be more common. In some factory workers, there might be some respiratory diseases which might be less common in the general population. So the occupation is important. And likely in very high profile jobs like in IT sectors or very office based jobs like that, there may be more depression, more anxiety in patients. So you may come to know about this by asking about his occupation. Like someone working in IT or in any high profile job, he may not have any other disease, but he may have anxiety. So by this you can know that the patient is having this occupation. So this person may be suffering from anxiety or this or that or any other disease. Then you will ask about the marital status. The marital status is important because in married persons there may be more prevalence of some sexually transmitted infections or STDs or sexually transmitted diseases. So you can know that, you can guess that by his marital status. Then how should we take the history? After asking the particulars, after knowing his name, his age, his occupation, his address, then we will go to the symptoms, principal symptoms. Firstly, I will ask his problem. So, okay, your name is this, your home is here, and this and that. Now, what is your problem? Why have you come here? There will be many symptoms. Like some patient may have fever, he may have pain in the leg, may have headache, may have cough. So one person may come with multiple complaints, like 3 or 4 complaints associated. He can come. So you will ask the first question, that what made you come here to me? Like, not everyone will go for cough, or not everyone will go for fever. So there must be a specific thing which made him to go to the doctor, that he cannot tolerate it anymore. So he has come here. So you will ask the principal symptom. This is not the principal symptom, the main thing for which he has come to the doctor. So you will ask it with the duration, like since how many days you are having fever, or you are having pain in the leg or in the abdomen, yeah, for how many days or for how many hours, since when you are having this. You let the patient describe by himself. So he will tell that, okay, I am having fever since 3 days or 2 days, or since yesterday night I am having fever. You let him describe by his own words. Then we will ask. Firstly, we will not ask any leading questions to the patient. We will just let the patient talk freely. He will tell by himself, okay, I have had these conditions, I had these problems. He will tell by himself. Then only we will interrogate. Firstly, we will let him tell by himself. Then inquire about the sequence of symptoms and events. Sequence, there should be a sequence. Like, they should not tell it haphazardly, like, today I am having pain, leg pain, yesterday I had fever, and then now I am having this. There should be a sequence, like, first what did you have? Then we can correlate that the leg pain is due to the fever, the chest pain is due to the fever, or the fever caused the chest pain, like that. We can correlate in this manner. So firstly, there should be a chronological order. Chronology means the sequence of events. So firstly, he may tell that, okay, firstly, I had I got a blow in my leg, or I cut my leg, I injured my leg. Then I had fever. Then I had these and that, these symptoms. So he should go chronologically in an order, like first this happened, then this happened, then I came here with this problem. Then I already told you that don't ask leading questions in the beginning. You will ask the patient to describe by himself what problems you are having. You tell me by yourself. You will not ask that what did you have. He will keep on telling. Then as I told you that there should be a chief complaint. There may be multiple complaints, like one person may have fever, he may have cough, he may have this and that. So the chief complaint would be one complaint generally. After that, we will write the other complaints also. So that is called the chief complaint, the main problem due to which he came to the doctor. He was bound to come to the doctor. He cannot tolerate anymore. So that is the chief complaint. So you will write that with the duration, like if he is having fever, we will ask for how many days you are having fever, or for how many days you are having loose stool or abdominal pain or something like that. Then history of present illness. We will write it, actually we will write it in a sheet. Like firstly we will write the chief complaint since these days, like fever since 5 days. Then history of present illness. Then we will ask him how was the fever, if the fever was high fever, or it was gradually in onset, or it was low range fever, medium range, or what was the temperature, like that. He will describe the illness. Firstly he will name the illness, I had fever, then he will describe the fever, like the fever occurs in the evening or in the morning, or it goes away itself, like that he will describe the fever. You have any condition. I am just taking an example of fever, so he can describe any condition. Then we will ask about his past history. Like in past history, firstly, commonly we ask if the patient does it, if obviously in accordance to age, if the patient is middle aged, we will ask that if he is having diabetes, or he is having hypertension or any other condition, or any kidney disease. We will ask him that does he know that he has this disease or not. Then we can correlate, okay, the patient is diabetic, that's why he is having this type of infections regularly. For diabetes this has occurred, or for this condition this has occurred. So we will ask about the past illness. So there is the past illness the patient is already having, or some events which may have occurred like 2-3 months ago or 2-3 days ago. Like I already told you that he got hurt in the, like he got hurt in his body part, or due to any condition this fever has arisen, or any other condition. So we will ask about the past illness, and we will ask about admission in hospital. Like did you get admitted for this condition or for any other condition in the hospital? Then we can correlate that the disease is a continuous disease. This is a continuous process. The patient is already having this problem which is arising after 2-3 months or 2-3 days, like this. By this we can know that. So we will ask about the admission, recent admission in hospital. Then we will ask if any surgery has occurred. Suppose if some patient is having pain in some abdominal part, then we can ask him if any surgery has occurred. So he may tell that, okay, I had some gallbladder surgery or this surgery or that surgery. 2-3 months ago. Then you can correlate, okay, that surgical site may have some new infection or anything like that. So in this way you can correlate that what caused the surgery, what caused the illness, by this condition, or you can know. Then we will ask about the family history. Family history means we will ask any patient the family history to know that if any disease runs in the family, like for diabetes, for hypertension, the family history is very important. If the person is having suppose a person is newly diagnosed, he is newly diagnosed with diabetes, like newly he has developed diabetes. Then we will ask him whether your brother, your mother, your father, or your sister, anyone has this disease, or like someone is having TB or any respiratory disease. So respiratory diseases are mostly communicable, as all of you know, that they will spread from one another. We will ask him that does anyone in your home has this condition or this disease. We will ask that things. So by this we can come to know that, okay, this is spreading, so it might be TB or it must be diabetes or like something like that. Then we will go to the personal and social history. In the personal history, we will ask if the patient is smoker or not, if the patient is taking alcohol or not, if the patient is having tobacco or not. We will ask these things so that we can correlate. So like some diseases are more common in some patients with who are smoking. Some diseases are more common in some alcoholics. Like liver diseases are more common in alcoholics. So we will ask about the personal history. Then we will ask about traveling. Like there is traveler's diarrhea. There may be typhoid due to traveling. Some people may have gone somewhere else. Say they took food there, so they might have some stomach poisoning due to that, food poisoning, and they might have typhoid due to that. So we will ask about the travel history, recent history of travel. As all of you might know that during COVID, everyone was asked if someone traveled to any other place or not. So that is the importance of the traveling history. Then pet or animal contact. Like if someone is having some allergy and someone doesn't know that he is allergic to cats or dogs or any other animal, but he is having cat or dog in his home. So that might be the reason of the allergy. If we don't know that he is allergic to that animal and that animal is present in their home, we will keep on giving medications, but the symptom will not, the patient will not get treated. So we need the animal history, contact history also, pet and animal history. Then about social history. Social history means in which conditions does the patient live. Is he living in a hygienic condition? Someone who is poor, maybe living in a small area, so there might be more risk of respiratory diseases or communicable diseases, or someone who is rich might not have those diseases. So that is the importance of the social history, social economic condition of the patient. And this is also needed for the treatment, for planning of the treatment. For some patients we can give some kind of treatment who can afford, and for some poor patients we will give another kind of treatment which he can afford. So these also, the treatment plan also depends on that history, that social history of the patient. Then we will ask about drug history, including allergies. Like if the person is having allergy to any specific food, like he came after eating like prawns, someone is having allergy to prawns, he came with allergy. So we will ask him, did you take prawns or did you take this food or that food? He might tell that, okay, after taking prawn, I am having this allergy, or after taking meat or something else, I am having this allergy. So we may correlate that, okay, he is allergic to meat or prawn or any other thing. So that is the allergic history is important. Then drug history is important. Suppose for any infection or any condition, he is already taking a drug. So he might develop a reaction for this, for allergy for the drug. So if you don't know the drug is causing the allergy, we will keep on treating the patient, but the patient will continuously have this allergy. So we should know the drug history of the patient. And it is also important so that some patient is, suppose he is having some disease, then we are giving him the same drug which he is taking for 3 days. Then it is of no use. We have to change the drug. So we will ask about the drug history. Then there is a complaint. There is an example. Sorry. Firstly, as I have told you, we will write about the chief complaint with duration. So this is the example. Like some patient came with chest pain. For 2 months he is having chest pain. Since 2 months, now ultimately at the end of 2 months, it is not tolerable. So he came here. So I will ask him, since how many days you are having chest pain? So suppose he tells me that it is of 2 months. So we will ask him that were you completely well before 2 months, or did you have any other problems before these 2 months, or it was present for 1 year or 6 months? So if he tells me, okay, I was completely fine before 2 months, since 2 months I gradually started developing this problem. So we will ask this. Then as I already told you that we will ask him that, then we will start adding questions by ourselves. Then okay, then what happened, then what happened, like this. Then we will start asking questions. So then we will ask him to describe his problems in chronological order. Like suppose someone is having indigestion problem. Suppose he was telling that, he will be telling that since 2 months I am unable to digest food, I am having problems with defecation or with this and that. Then I am having this stomach, this pain in my abdomen or pain in my chest. Then we will elaborate, like we will tell him to explain like this. What happened after what? We will tell him to explain like this. Then about the pain, we will ask for the site of the pain and the onset. Site of the pain means look, our chest is this much big, na? The pain might be here also, might be here also, might be here also, might be here also. So we will ask him to tell the exact site of the pain, where the pain is. If the pain is in left side, that it might indicate that the patient might have some disease of the heart disease might be there. If it is on the right side, then the heart disease is not completely ruled out, but we can think less of the heart disease. Okay, that might not be a heart disease, might be a muscle spasm or muscle pain, something like that. So we will ask him to tell the site of the pain. In case of any abdomen pain also, because there are various organs in the abdomen. So if some certain part is getting affected, there is pain in this region, then we will think about this organ. Okay, this organ might be affected, like that. Then we will ask if the pain is acute or gradual. Acute, what means that something occurred suddenly, like since yesterday night I am having severe pain in my abdomen. So this is acute. Like since 10 days I am having pain in my abdomen. So this is not acute, this is gradual. Like since 10 days I am developing pain continuously, it is growing and growing. So that is called acute and gradual. Then there is character of the pain. Character means there are different kind of pain. So you might be hearing people telling that I have this type of pain. So there are different type of pain. Like character, there is feeling pressure. Like in myocardial infarction. In myocardial infarction, what happens that the patient will tell that I am feeling like someone is sat in my stomach, in my chest. Someone is sitting in my chest, or someone has put a stone or brick in my chest. I am feeling heavy in my chest. This is called feeling of pressure. Then there might be a dull pain. Dull pain means like if in the abdomen, if someone is having pain. So he cannot localize the pain. In case of dull pain, the pain is constant. It is not that much that you are not able to do any work or anything. You are stopping in your tracks. You are holding your stomach and sitting. Not like this. There is constant pain, but not that much. You are able to work. You are able to do your regular task, but there is a constant pain which is annoying you. So that is called dull pain. Then there is stabbing and shooting. And stabbing and shooting are nearly same only. Sometimes in some diseases, someone might have faced that there is sharp pain, sudden sharp pain in your abdomen. So you are holding your abdomen and sitting down. There is so much of pain, unbearable sudden pain. So that is called stabbing pain. You will feel like someone is pricking you, someone is stabbing like this. So that is the stabbing pain. It is usually acute in nature, because obviously after this pain someone will go to doctor, or someone will get admitted. They will not sit with the pain. So that is always acute in nature, stabbing pain. Then there comes radiation. Now radiation, what means? Radiation means okay, some person may have pain in this area. The disease might be in this area, but the pain he is feeling would be here or there, like that. There is one example for radiating pain. Radiating pain is like in myocardial infarction and acute pancreatitis. In MI, myocardial infarction, you know that there will be disease of the heart, disease of the coronary arteries. When it gets blocked, then there is pain in the chest, in the heart. So that is a type of compressing pain, a heaviness of the chest. So in this case, there might be sometimes pain in the arm, pain in this arm. There might be pain in the middle of this arm. There might be no pain in this area, but pain would be there. Then if we do the ECG, then we will find that the person is suffering from myocardial infarction. So that is called radiating pain. Radiating pain means the pain has started here and suddenly it will go here. Like the pain, originally the pain is here, but you are feeling it here. That is radiating pain. Like for example, myocardial infarction. And in acute pancreatitis also. You are having pain, like you are having pain in this area, but it will radiate to the back. The origin of the pain is pancreatitis, is in the pancreas, but you are having it is in the back, in the lower back. That is a type of radiating pain. There is another type of pain which is called referred pain. Referred pain means simultaneously in both parts you will feel the pain. Suppose for example, in gallbladder pain will be referred to the right shoulder. In this one, in referred pain, the pain will shift. Like if you are having pain in the gallbladder, you have a problem in the gallbladder or inflammation, this will be shifted to the right shoulder. You will feel the pain in the right shoulder, but the disease is in the gallbladder. So you should correlate with that. Okay, he is having pain in this area, so might be he might be having cholecystitis. And in case of radiating pain, the pain will radiate to another area. There will be constant pain in both areas, like in heart also, in arm also. There will be pain in both areas. Then there is another type of pain, radicular pain, which is caused by compression of spinal nerve. You might have seen old people complaining that I am having pain in this area, in the lower back, and there is some tingling sensation, like someone is pricking in his leg, or there is some burning sensation in his feet. Like this, the pain is going like this. He might have some pain in his lower limb, left lower limb or right lower limb, but he is having pain in this area, in the back, in the spine. He is having pain. So this is caused due to nerve compression. As you age, the nerves may get compressed due to the damage of spinal cord. So this nerve compression will radiate the pain as the same nerve is carrying through the whole foot, the whole leg. So the nerve will carry the pain downwards. So you will feel the pain in the whole of the area where the nerve is supplying. So suppose you are having pain in the back, or in case of spondylosis also. In case of spondylosis, like someone is having pain here in the neck, he is having spondylosis. So there may be pain in the shoulders. He might have pain in the shoulders. That is also another type of radicular pain, referred pain also. Then after pain, we will ask about the severity of the pain. That the pain are of different classes, different types. Like some pain, which I already told you that with some pain you may be able to work completely fine. Just you are having some pain. When you think about the pain, there is pain. But except from this, you are able to work properly. So that is one type of pain. That is low. That is not so severe pain. There is mild type of pain. Then with severe pain, there may be interference of work. For some pain, you might stop coming to college. You might stop going to work. There is that kind of pain, and you might not be able to sleep for this pain. So that is a severe kind of pain. So we will ask if the pain is this much severe, or it is mild or moderate. So then we will ask about the precipitating and the relieving factors. Like in this example, I will tell you about heart disease, like angina. In angina, everybody listen. In angina, there would be decreased flow of blood to the heart. The arteries which are supplying the heart, they themselves will get clogged due to cholesterol or either anything. They might get clogged, for which there is less blood supply in the heart. So as the heart pumps blood to the whole of the body. So if you are doing work, obviously the heart will pump blood, but the heart itself is not getting blood. So obviously the action of the heart will get affected, as it is made of muscles. The muscles are not getting enough blood, so the heart will have to work more. So this will cause pain. So this is a type of precipitating factor in angina. Precipitating factor means like some person, suppose I am having angina or any person is having angina. If he walks or if he does some play, if he plays in sports or anything, he will start to have pain. So this is the precipitating factor. Precipitating means something which is increasing the disease. This is the precipitating factor. And there would be relieving factors. Relief means the patient is relieved. If he does something specific, he is relieved. Like in angina, if the patient settles down, if he drinks some water and he settles down under the fan and all, if he relaxes, the pain goes away. Then we will know that okay, this person is having angina, so he is having these precipitating and relieving factors. If the person is not having this kind of aggravating and relieving factor, we can think okay, the muscle there is some muscle spasm, tightness of muscle might be there. This might not be a heart disease. So by this we can diagnose. Then we will ask about this history of pain. Like did you have this pain earlier also, or just now are you having this pain? Like someone with heart disease might have this pain since last 1 year, or someone with muscle spasm might have this pain for today, since today he is having this pain. So we will ask about the history, if he is having the pain from since early time, or this is a new pain. So in angina, pain will be associated with nausea and sweating. Like when there is pain in the heart, in the chest, left side of chest, then there will be accompanied, this is accompanied by nausea and sweating. Like in normal, like if you are doing any hard work, you have carried any heavy object or anything, like you have pulled a muscle, there is some muscle spasm. So that will not cause sweating, that will not cause nausea due to pain. That will be due to mostly due to muscle spasm. There will be tightness in the muscle. So that will not cause nausea or sweating. But in angina, there will be pain. Along with the pain, there will be sweating. The person will sweat profusely, like if you both of you are walking together, but you will not sweat. The person will start to sweating heavily. Then you will know that okay, his heart is not working this much. He is having some problem in his heart. That's how we will come to the diagnosis that he might be having angina. So by history, we can know all this. Then mostly in OPD patients, we see the patient will come by himself. He will tell, okay, I had this problem, I had this problem. But in emergency and in ICU settings, when the patient is critically ill, like someone is hit by a bike or a car or anything, the patient has fallen down for 3 stairs or fall down from a tree, that patient will not be able to give you history, he will be unconscious. So he cannot give you history that I fell down from a tree, I got unconscious. He will not be able to tell like this. Or any person, any old person, like who is having severe respiratory distress, he is not able to breathe properly. So how can he tell you that okay, I had this problem, I had this problem? He is having difficulty in breathing only. So he cannot tell you. So in case of that, we will ask the relative of the patient. So okay, you tell that what was the problem. So he will be better person to tell it. But we will not ask just anybody. Like someone has underwent an accident. Suppose someone has underwent an accident in front of you, then or in some locality. So some people will carry him to the hospital. So we cannot ask him that. We can only ask him that how did the accident occur? Was he hit by a bike or a car or anything hit him or anyone beat him like this? But you cannot ask him that what medicines he is taking, what is his condition. So obviously we should ask this to the relative only. The patient will also not be able to tell if the patient is having head injury, a severe head injury, if he is unconscious, nearly unconscious, or if he is not in a condition to tell you. So obviously you cannot tell the patient, you wake up and tell me. Obviously you cannot tell them. No? So we will not ask even the others that who brought him, okay, you tell his history. Obviously how can you tell? He found him in the street. So for that we will wait for the attendance of the patient, and that should be reliable. Not like that, okay, my mother's sisters, this, and he has come. Obviously the closest person, his father or his brother or whoever is staying with him in his home, that person will be more reliable. In case of children, we will usually ask the history of the mother, because the mother is the best, she will be knowing best about the child. So in case of children, we should ask the history from the mother. Then the attendant, after the history should be taken from an attendant, a close one. Then we will ask about the past history. I already told you that we will ask about the past history, that if he is having diabetes, if he is having some illness. Like if a person is having a severe injury in his leg, if there is a deep cut in his leg, for diabetes patient we have to treat him differently, because he might develop an infection rapidly. The other person with less age might not develop infection so quickly, but a person who is having diabetes or any kidney disease or any other disease, he is ill from before only, that person will develop a rapid infection or he will deteriorate more easily. So we have to know about the illness, if there is any previous illness. Then we have to know the hospital admission. Like the case which I am treating, the patient is already taking treatment for this, but there is no cure. The patient is not getting cured. So I will have to think of something else. Now, if I keep on giving the same medicines which he is getting, then how will he get cured? He will get the same treatment only. So we should ask about the hospital admission, recent hospital admission. Like then any operations, I already told you that we will ask about the operations. If he had his gallbladder removed, if suppose he has his gallbladder removed, obviously there will be no pain in his gallbladder because there is no gallbladder. So if I keep on searching for his gallbladder without knowing that okay, he had his gallbladder removed, then obviously that will be of no use. So that is the requirement. That is the thing for which we should ask if there is any operations. And medicines, again, I have already told you that we ask for the medicines. Then we will ask for the family history. I already told you that father and mother, if they are all right, if they are having any disease in their home, like any respiratory disease, any cardiac disease if they are having. So we will ask about that. Again, about hypertension, diabetes, we will ask for that to know that if this is a family history. Some people are having family history of diabetes. Someone is having, no? He is having a family history of diabetes, I know. So we will ask that if someone is having family history of diabetes, so he is more prone to develop diabetes. So then if any history of death is there, suppose wait, listen. Suppose some patient has come with he is diagnosed with chest pain. Not diagnosed, he has come with chest pain. His complaint is chest pain. Then he gave a history that his father has died at the age of 50 or something else due to a heart attack. Then obviously we will think that okay, there is a problem of heart disease in his family. So we will look like that. We will change our mode of treatment like that. Okay, he might be having a heart attack. So we will look for that. Otherwise we will keep on doing so many tests. We will do X-ray, we will do this, do that. In that meantime the patient will die. So obviously we will think in that way. Then how many brothers and sisters, as I already told you, how are they, if they are having any disease or not. Ask about their job, their marriage, then their children's. This point I already told you, I think. Then we will ask about smoking history, alcohol history, any medicines, any allergies. Then if the patient is old, suppose if the patient is old and he is having angina, I told you that there will be decreased blood supply to the heart and he will have chest pain. So we will ask him whether you are living ground floor or in the upstairs. So if you are living in the upstairs or you are living in ground floors. So obviously if he is living upstairs, that pain he will face daily. Whenever he is going to his home, going to his room, then obviously he will face this pain. So we will ask that whether he is living in ground floor or in upstairs. Then if he is having any difficulties regarding toilet, cooking, shopping, like this is normal task, na? We all can do these things. We are going to toilet, we are cooking our food, or we are shopping. Normally we don't face these problems. But if someone is having problems in cooking also, going to bathroom also, then he might be having some disease internally. That might be some disease, some respiratory or some cardiac or any other disease might be developing inside him. So we should ask these questions also, that if you are able to perform your normal task or you are having difficulty to perform your normal task. Then okay, this concludes the history. Then after the history we will start general examination. Suppose you have gone to a PHC. Suppose you are working in a village setting. So there people cannot afford that much medicines or that much tests. Like if someone has come with fever, you are giving him okay, malaria, typhoid, dengue, this everything. You are giving him 10 lists. You go and do this. He cannot do this. He will not come to you again. So you have to be specific, that you should know by his history that okay, he is having fever since this much time. His house is here, so it is a malaria prone area, so he might be having malaria. So okay, you give 1 or 2 tests like malaria and dengue. Sometimes malaria may come positive. So that is the way by which you reduce the burden over the patient. If you are writing 10 tests, 15 tests, obviously he will not be able to perform, he will die due to the disease. So there is the importance of the history. You can use it anywhere. Whether you are having resources or not, you are working in a big hospital or in a small hospital, by history you can know many things. So that is the importance of the history. So after history, we will start the general examination and the systemic examination. General examination we will do for everyone, and systemic examination by history only we will know that which system should I focus on. Then we will start the system examination. So the general examination will be taken now, sir.
Good afternoon, everyone. Yeah. So sir has taught how to take a proper history. This is a cornerstone for every clinician to take it properly and to develop the skill. With time you will be able to develop your skill. I know you are not being able to see the signs and symptoms, but during taking the history, but you have to be very much precise, and there are, as sir said, the procedures for chief complaint and presenting illness, you have to describe it accordingly. So now I will be continuing with the general examination part. So in general examination, first when the patient comes, you have to see the appearance of the patient. So whether the patient is looking well, whether he is ill or not, whether he can walk properly, whether he can talk properly or not, So the general appearance is the first. So whether the patient is alert or not, whether his general behavior is good or not, and whether he is oriented to time, place, and person. So you have to ask him where are you right now, or what is the time, or the accompanying person with whom he has come, whether he can say this or not. So whether he is confused or drowsy, you have to see this, and whether the patient is obese or not, whether he has any wasting of muscles or not, whether he is thin build or not, okay, whether he is in pain or distress. So you have to see in all these things in general appearance. So after that, in general examination, you have to see the hands and the nails. So you have to see whether they are cold or not, whether they are warm or they are sweaty. In anxiety, some anxiety patients, you will observe that the palms are sweating. One of your friend, who is that? I don't know. He came in the OPD. He was having sweating in his hands. He came for that. He had this problem for a long time. I advised him some tests, but he hadn't visited me again. So in some conditions, we see this sweating of the hands frequently. So after that, we'll see peripheral cyanosis. Peripheral cyanosis means we'll observe the tips of the fingers, whether there is any bluish discoloration or not. In some conditions, there is a decrease in the oxygen concentration in our body. So due to the carbon dioxide level more, so there is the bluish discoloration. I think it's more than 5 gram%. Okay, at that time it's visible. So the nicotine staining, we'll see there are pictures, and in Raynaud's phenomenon, again due to this peripheral vascular disease, there is loss of blood supply in the fingertips, and there is coloration, discoloration of the fingers, and there are certain stages in that we'll learn later. Then the palms, in chronic liver diseases, we'll see there is red coloration of the palms. And in pregnancies also sometimes we see. So there is Dupuytren's contracture. In that we have a thickening of the palmar fascia near to the flexor tendons. So this happens in diabetic patients, in alcoholics we see this. So in nails we'll see mainly the clubbing, the color of the nail. So in clubbing, there is actually thickening of in the base of the nail with the structure of the soft tissue. So there is the loss of the angle. So there are various grading of clubbing. There are some tests to grade the clubbing. So the first one is a fluctuating test. So you will see in our books it's written. So in fluctuating test, we just press the focus on the fix the distal phalanx, and with the help of our tip of the finger, we just press it from one side and feel it with the other finger. So you can come here. I'll show you. If your colleague, if the patient or your colleague had clubbing, so we'll fix with the middle finger, and we'll feel with the index finger. So these two fingers, this middle and the thumb finger, we have fixed the finger of the patient, and the nail bed will just press, okay, and feel with the other finger. Okay, we'll fix with the middle finger and the thumb finger here, the nail, and then we'll press the bed of the finger. The nail of the finger bed will press with the one finger. Suppose I'm pressing with this finger, my right index, and I'll feel with the left index. So this is a test. So in grading, when the grading increases, the loss of the angle is lost. Okay, the normal angle is 160 degree, and with the increase in the grading, the angle is lost.
Sir,
yes.
what do you find out by
There is increase in the soft tissues in the nail bed. Okay, so when we press it, you will feel a pressure in the other finger. The soft tissue is pressing you on the other nail. You'll feel that thing. Okay. So in some conditions, like in infective endocarditis, we see this in lung, like in bronchial carcinoma, and bronchiectasis we also see that. In liver cirrhosis we see, and in Crohn's disease also we observe this thing. There are some. This is the picture of a patient having clubbing. So you can see there is increase in the soft tissues and the nail of tissues of the finger. So the angle is normally our finger we have is 160 degree. So the angle is lost here. So with subsequent grading, there is increase in the tissues of the nail bed, and the final grading, the wrist is also swollen. Okay. So can anyone see the shape of the nail? Have you seen the shape of the nail here in this picture? It is actually spoon shaped. So in iron deficiency anemia, we normally see this type of nails. Okay. So this is another picture. This is known as leukocytia. So in liver diseases, this whitish coloration of the nail is formed. So you know what is the function of the livers? And protein synthesis of protein. So in hypoalbuminemia, we see this type of nail in liver dysfunction. Okay, so this is one picture showing there is a reddish brown line in the nail, which normally we can see in bacterial endocarditis. So, and this is another picture of the nail. There is pits or dips in the nail, which is irregular. So in psoriasis, we normally see this type of nails. This is one picture of the palm. As I said, in diabetes or in alcoholics, there is thickening of the palmar tissue and contraction of the flexor tendon. So this finger will be flexed like that. Okay. So after applying pressure only, you can make it to its original position, or it will be contracted like that. Okay. So in one condition is there known as onycholysis, which is separation of the nail from its nail bed, which is also seen in psoriasis and thyrotoxicosis. What is thyrotoxicosis? Increase in the thyroid hormone. Na? When you hear the term toxicosis, means there is toxicity. Na? So after when anything in your body is beyond the normal range, or it's elevated very high, that time this is we can say it as toxic. So it's written thyro and toxic, means thyroid hormone increased very much. Okay. So in the face, we will see mainly the mouth, whether his tongue is moist or not, or dry or not. In dehydrated patients, we see the tongue is very much dry, or the patient is moist or not. When we see the tongue is moist or not, name some conditions. Can you say? Okay. So in which conditions we see the tongue is dry? Like in dehydrated cases, we see. Na? What can be the causes of dehydration? Huh? Okay, then. Any more? Huh? Diuresis. Okay, then. Anyone? Infrequent vomiting. That time also we can see. Okay. So then cyanosis, we have two types mainly, the peripheral and the central cyanosis. So in peripheral cyanosis, we see as I said, the bluish discoloration of the finger toes. Thus the peripheral circulation of the fingers is not well. So there is color change. In central cyanosis, we will focus on the central part, means the nose, that lips. There we will see there is bluish discoloration. So in conditions like tetralogy of Fallot, we will see this, and in obstructive airway, So there is not mix. The mixing is not proper. Okay. So the oxygenated blood is mixing with the deoxygenated blood in like valvular disorders. Okay, or the septal disorders there we see. So there is improper mixing. There we see the central cyanosis. In mouth, we will see the dental hygiene, any cares whether present or not, the gums whether it's bleeding or not. Name some condition. Yes.
Can you put the previous slide? Just please.
So can anyone say name one condition in which there is bleeding from the gums? Yes. This is because. Yes. Then the smell of the breath. We don't need to actually smell like frequently, but in some patients, like if you see and you can diagnose, or it's diagnosed from before, if the patient is a known case of diabetes or having liver disease. So in these patients we can find a smell. Like in diabetes patient, we can feel his breath of ketosis. So what is that ketosis? So why is the smell like? Yes. So the ketone bodies is not being able to excrete from the urine and the stool. So it's being released from the breath. So we are getting that smell. And in hepatic failure, like in liver disease, in alcoholic patients, we see this is a smell of the compound known as mercaptans. Okay, mercaptans. Okay, so there is increase in the gut bacteria which produces that smell. We normally find in those patients. And in eyes, you can differentiate between sclera, conjunctiva, iris, pupil. Can you differentiate? Have you seen? See this picture. Which part is the sclera? Yes, this part, na? This part is the sclera, and this part. What is this part? Cornea. And inside the cornea, that muscular part, what is that? No? What is that called? This is iris. And this iris contains how many muscles? No. You? So it contains two types of muscles, longitudinal and circular muscles. So this helps in contraction and relaxation of the iris. When you see direct sunlight, it constricts. When in the not being able to hear this part. So I was asking how many types of muscles are there in the iris. So can you say? There are two types of muscles, the circular and the longitudinal muscles. Okay, so these muscles helps us to focus. When there is illumination mode, it constricts, and in the dark room it will dilate. So that time our rods get activated. Inside the eye there is two types of cells, rods and cones. So this is the iris and this is the pupil. And in anemic patients, we'll see the lower palpebral fissure. Okay, lower palpebral conjunctiva. Sorry, this part we will see for pallor, and the upper side or the sclera we will see for jaundice. Right? See this patient. So there is yellowish discoloration of the sclera, right? This part, and his skin is also discolored, You can see in the screen. This is a picture of peripheral cyanosis. See, there is discoloration of the fingertips and the legs. You can see. So this is due to peripheral vascular disease. Okay, or you find it in some systemic cases also. You'll see this. This is a case of central cyanosis. We'll focus on this part, the nasal, the lips, and the tongue. You'll see there is discoloration. It will be mainly bluish. Okay, so when the level of the oxygen reduces very drastically or for prolonged time, we can see this. So one more picture is there. See this picture. This is known as xanthalasmana. There is deposition of cholesterol around the orbit of the eyes. See, you can get it physiologically also. Okay, like this patient, this might be physiological also. Okay, and in this patient, this is known as arcus senilis. Senilis. So there is a whitish ring on the cornea. So this is due to deposition of cholesterol. Okay. In hypercholesterolemia, we will get this ring. It's hyperlipidemia, but little significance. There is white band keratopathy and hypercalcemia patients we will see, like in known as sarcoid or in parathyroid, in lung cell tumor, or in vitamin D excess intake. The time we see this. So in eyes we also see whether the conjunctiva is inflamed or not. Okay. So if the conjunctiva is inflamed, this can be a condition known as conjunctivitis or iritis or episcleritis. So we will see this. So in younger patients, mainly we will see this arcus senilis and has little significance on elderly patients. You can see there is the orbits is looking swollen. Na? It's swollen, right? Na? So in which conditions we see this puffy eyes or puffy face? And you say hypothyroidism, and like this is swelling because of what? There is excessive fluid accumulating in our interstitial space. Na? So in conditions like if the patient is not being able to clear his urine, or the fluid of the body is not well maintained by the kidneys, in kidney, that time we can see like the water is being deposited in our body parts. Okay, so in kidney disease we can see like name one condition in which we can see CKD. This is a broad term. In nephrotic syndrome we can see. In nephrotic syndrome what happens? There is loss of protein through the urine. Okay, so the level of protein in our body is decreased. So what is the role? You have studied hydrostatic pressure, oncotic pressure. What is hydrostatic pressure on the then what happens if the hydrostatic pressure is increased from the normal range? What happens? Yes. So the reverse happens in oncotic pressure. Always remember. Okay. In oncotic pressure, the fluid where in hydrostatic pressure it goes from inside of the blood vessel to the interstitium. The oncotic pressure helps in bringing the interstitial fluid to the blood cells, blood vessels. Okay. So if there is hyponatremia also, hypoproteinemia also, there is less protein in the body, the fluid will go outside the vessels to the interstitial space and it will accumulate also. Okay. Always remember this. Sclera you have seen, and for anemia you have focused on the lower palpebral fissure, conjunctiva, and mucous membranes you have to also see. The cyanosis part, the cyanosis you can also see under the tongue. Okay, under the tongue and on the tongue for pallor. Okay. Then the generalized may have said trophy in nephrotic syndrome. There will be generalized edema, and in mixed edema. What is mixed edema? What is mixed edema? That is, have you heard hypothyroidism? This is the severe form of hypothyroidism. Okay. So in hyperthyroidism, the patient becomes thin-billed, or there is increase in the metabolism of the patient. So he becomes thin-billed, and there is wasting of loss of muscles and the other structures. In hypothyroidism, there will be the metabolism is less, so he will gain weight, and there will be deposition of the fluids. This is actually a multi-organ failure. This is a severe form of hypothyroidism. Okay. So that time, due to the multi-organ failure, he becomes edematous. So that I have already said. This is also, I have say, arcus sinalis. And this is one picture in Wilson's disease. Naturally, this happens. There is deposition of copper in the cornea. So this is known as, what is it known as? Cassius ring, na? Cassius ring. So this happens in Wilson's disease. This is one of the patient of myopathic. So actually here due to the weakness in the muscles, kindly please pay attention. In this patient, we can see there is, what you can see in the patient face, is the face looking normal. What you can see here? The eyes are a little bit drooped, na? The cheeks are also a bit drooping. Eyelids and also drooping. So actually, due to muscular weakness, there is this findings. So we'll see this in subsequent classes later. So this is a case of a pitting edema. So what is pitting edema? And louder.
If you squeeze
No, actually there is accumulation. You can see there is accumulation. There is swelling of the lower limbs. So we have to for this we have to press in the bony surface with the thumb and press for at least 10 to 15 seconds. That time we will see pits. So there are two types of edemas: pitting edema and non-pitting edema. So in pitting edema, this we can see in renal causes, in hepatic causes, and in cardiac causes we can see these cases. Okay, but there is also one type non-pitting edema. If you press, there will be swelling of the lower limbs, but if you press in the bony surface, you won't find pits. So in which conditions we can see, if any person is injured or he got fallen, so that time you see if you press there, you won't find pitting. Okay, so in cellulitis cases we can find this, and in one condition where the lymphatic supply is not well enough, okay, in any obstruction in the lymphatics, that time we can see. Name one condition where we can see non-pitting in lymphatic obstruction. Yes, in filariasis we can see there is obstruction in the lymphatic flow. So that in this condition we can see. Okay, this is another condition of the skin where is the reddish coloration. In inflammatory bowel diseases and sarcoidosis we can see there is nodules formation on the skin. So this is also a case where due to inflammatory bowel disease there is gangrene formation on the skin. So this part of the tissue is dead and it's necrotized. So in Crohn's disease and ulcerative colitis, we can see this. So after taking the history and examination, you have taken him all the history and you have examined him. So you have to ask after this whether he has any questions in his mind or not, whether he has any doubt regarding this. So you have to explain him, and then you have to thank him. Always remember to thank him or her at the end of the examination. And then you will proceed to the systemic examination. So this will be carried on the next class. So one thing I want to say, as your sir has told for the one, let me show you. I think this is not much needed now, but if you know it from before, it will help you in the when you go in the next classes or in the next academics. So like pain, this patient this patient is complaining of pain here so always you try to go with the one mnemonic is there for pain. This is known as SOCRATES, SOCRATES. Okay, so always go with this mnemonic for pain description. So as for what? Yes, side. On which location the pain is present in the chest or abdomen. Then O for on origin or onset, from when it started, the date or the month or the time from when it started. And then C for character. Yes, character of the pain. As sir said, the pain may be dull pain, heaviness, or it may be stabbing pain or throbbing pain. Okay, you have to see this type, how to differentiate between this pain character. Then R for radiation. Yes, through where it's radiating, whether it's radiating towards the limbs, left hand, or towards the back or anywhere. Then A for associating factors. So whether the pain is associated with shortness of breath, whether he's having difficulty in breath, or there is palpitation, anything like that. So then T for time or duration. Okay, for how long duration he is having. And lastly E. Yes, E for no, it's aggravating factors, aggravating or relieving factors. Okay. Aggravating or relieving factors. Okay. Not E, it's A actually. Okay. It's A. SOCRATES. Okay, so aggravating or relieving factors. And last one S for No, pain I have, the character you have said. S for S for what is that?
Side of pain is done.
Severity. Okay, severity. So the pain you can scale from 0 to 10. Okay, if the pain is little, you can say it 1, or the pain is unbearable, you can up to 10. So you can ask this and tell him to describe according to your grade. Okay. So with this you can actually able to go to a differential diagnosis and further systemic examination and everything after that you will be able to diagnose this patient. Okay, so go with this pattern. Okay, I think it will be able to, I'll be able to help you in this class. Thank you.